My name is Kim Burney. I'm the current president of the Association for Glycogen Storage Disease, or AGSD. At AGSD, we're committed to the identification, treatment, and cure of glycogen storage disease. We do this through programs of education, advocacy, research, and other patient services. To assist with our mission, it's very important for us to grow and share best practices and key findings, along with other organizations in the rare disease field and community, and that have similar goals. One of these alliances has been with the APBD. Through our collaboration with the APBD and with the AGSD Scientific Advisory Board, we've been able to complete the current glycogen storage disease type 4 guidelines. These guidelines will provide standardized medical guidance to individuals and families worldwide. Today, I've been asked to introduce Rebecca Koch. Rebecca has just done a phenomenal job writing, coordinating, and finalizing the type 4 guidelines with the multinational stakeholders along with AGSD. It's really been a pleasure working with Rebecca, and I feel honored to be able to introduce her today. Rebecca is a clinical and translational research in the Division of Medical Genetics at Duke University Medical Center. She received her bachelor's in dietetics and her PhD in nutritional services, and she is a registered dietitian. She works on Dr. Priya Kishnani's research team, where her research focuses on better defining the disease progression, pathophysiology, and factors related to treatments and outcomes related to inherited metabolic disorders, including glycogen storage disease and others.
Can I take it away from there, Kelly?
You sure can. Thank you, Dr. Koch.
Yeah, no, thank you guys so much for allowing me to invite these panelists. Really, that's who I'm here to introduce. So one second, let me share just a few slides here. All right, again, I'll rely on you to tell me if this is correct. Does it look good?
Looks great.
Okay, perfect. So I won't introduce myself since Kim already did that, but thank you, Kim. I know you couldn't be here today, but thank you for that kind of introduction. So really my goal here today is one, to introduce our panelists and have some discussion about what these guidelines are and kind of our experience with them. And also to hear if there are any questions. I'll be looking at the chat, but if there's any questions from the group as well that you have about this. So I'll be moderating a panel discussion today. I have some questions of my own for everyone. And then of course, if you have some questions, I'm happy to build those in. So I won't spend long on an intro, just to get us all on one page. This is a guideline for both glycogen storage disease type 4, the pediatric form, and the adult form, APBD. So just a reminder, APBD is a glycogen storage disease, meaning you cannot create or use glycogen properly. So there are several types, and today again we're talking about glycogen storage disease type 4. I made this very basic visual just to show that again it's affecting both children and adults in different ways. So the overview of this guideline is to develop a practical resource tool for clinicians and patients that will address both the diagnosis and management of GSD4 and APBD. And we do this by highlighting what we call the current best practice and consensus for those, if, as you guys all know, the literature can be scarce in different symptoms. So coming together for consensus on different topics. So ideally, this guideline is for the primary audience of our clinicians, so everyone involved in patient care. But secondary audiences that this is really, guided for is for emergency physicians, so people who are not familiar with the diseases, but patients will be presenting possibly to the emergency room. They need to know how to get proper care and especially educate those emergency physicians on some of these immediate care tools, as well as the patients themselves, of course, family members, and the community at large. So for our children, this is more, towards the teachers and social workers, but of course for adults as well, and the community at large that they're involved with. And ideally, the language in this guideline will be suited for both an educated patient and their primary physicians. So the way I word this is it's really helpful for the experts, but also for the primary physicians who may never see this disease ever again. They'll only have a patient one, and they need to know how to best care for these patients, because what we don't want is the patients having to travel to expert centers, possibly around the world. It's expensive, and if they can get some of their care managed locally, that's our goal. So this is not a new tool, I guess, if you want to call it that. These guidelines have been written for other GSDs. So years back, there was one written for GSD1, and over here on the right for GSD3. also for GSD type 6 and 9, it came out a few years ago, and most recently for GSD 5 and 7, that came out just a few months back. So there are 19 of us, a lot of us are already in this room, but 19 of us that have come together to create this glycogen storage disease type 4 and APBD guideline. And so there's expertise, I will not bore you with all of the different names, but all across the disciplines that are involved in this care. And this is just a visual of where we are all located. So I do want to give a caveat. This is a US-based guideline. We did that for a couple of different reasons, but really we hope that the consensus here can be applied across the globe. And we do hope to submit this in late fall. So fingers crossed we are on timeline. So here's just a picture of all of us at our first meeting. I think most of us were fitting here in this picture. So you'll recognize a few faces that are here today. So bringing us to our panel, I'm honored to introduce our 4 panelists here today. So starting off with Dr. Diksha Bali, she's a professor of pediatrics in the Division of Medical Genetics at Duke University. And she's also the director of the Biochemical Genetics Laboratory at Duke University. She has extensive experience with glycogen storage diseases, and she also serves as our diagnostics and enzymology expert for our guideline. Then next, Dr. Jennifer Orthman Murphy is an assistant professor of neurology and the co-director of the H. Span Fellowship in the MS Neuroinflammatory Disorders at the University of Pennsylvania. She's also faculty at the Mahoney Institute for Neurosciences. And she is joined on this guideline to expand on her expertise in neuroinflammation. Dr. Andrew Landstrom is an associate professor of pediatrics, the director of Duke Pediatric Research Scholars Program for Physician Scientist Development, and he's also an associate professor in cell biology. And he's a physician scientist who's trained in pediatric cardiology with a focus on arrhythmias and genetic diseases of the heart, and he is our cardiologist for our guideline. And then Bridget Keeley is my partner in crime, and she is a 3rd-year medical student in Duke University School of Medicine, and she's finishing up her research year with us, and her research is focused on glycogen storage disease type 4. And so she again is with me on all things GSD4 and APBD and has been instrumental in the creation of this guideline. So I will stop sharing so that way we can just see the panel. Perfect. So I'll start off with a few questions for all of you. And then of course, I'll be moderating the chat, everyone. So if you have any questions, please put them there. So to start off, can you walk us through how each of you have taken either your experience or the literature or both for your respective section or sections in this guideline? So I'll just call out a name if that's okay, and then we can go in order. So Dr. Landstrom, I see you first.
Thank you, Becca, and thanks for everyone's participation with this. This has really been a pleasure. I'm excited to have the chance to be with you today. So basically, it's limited clinical experience because these diseases are, of course, very, very rare. But as well, we leveraged a bunch of case reports and small case series from the literature to develop a scope of the cardiology practice in this space, and to use that as a foundation for developing consensus.
Awesome, and I know our answers will probably repeat, but to give us personal twist, so I see Diksha next. You're muted, Dr. Bali.
Hey, good morning, everyone. Thank you very much for letting me be part of this group, and it's a pleasure to join you all. And as Becca said, that I am director of the Biochemical Genetics Lab, and I have been involved in the diagnostic and clinical studies involving all the GSDs, and most recently GSD type 4. And we have published a lot. And as you can all understand who are in this group, that APBD is one of the hardest phenotype in GSD4 to diagnose using enzymology. So, but we still get quite a few samples for diagnosis, either muscle biopsies or skin fibroblasts, and we try to diagnose. But for accurate diagnosis, you do need to have a mutation analysis of GBA1 gene for accuracy of diagnosis. So as Becca said, a group of us have come together to put the guidelines for the diagnostic part of the GSD4, including APBD. Thank you.
Awesome. And then Dr. Orthman Murphy.
Thanks for having me. So I don't have a very good short answer to your question, but essentially, just for a little bit of context, as you introduced me, I was trained in MS and neuroimmunology, and I made my way to APBD because as a fellow, I was frustrated that there were people that did not fit the MS diagnosis or common disorders, and we didn't know how to, what the next step was in diagnosing them. And so taught myself neurogenetics, started a neurogenetics clinic in complement with my MS clinic when I started here at Penn a few years ago. And APBD was the first diagnosis I made. And so the first thing I did was contact APBD to say, well, what do I do? And had a conversation with Dr. Kolodny, who just sort of introduced me to the field and what was going on and what the Research Foundation was. And since then, I have diagnosed more people. And still, typically from the MS standpoint, I know what to do. I know what to follow over time. We have guidelines for how to diagnose and manage and surveil and change strategy and symptomatic management. And I just think it's really exciting to put this, make it a concrete thing so that, not only can super subspecialists, like I would consider myself, but this is something that can be shared, and you could ask the super subspecialist questions, but there's some things that you can do at home, just like Dr. Koch said. And also I appreciate that Dr. Koch also launched into my other interest of actually neuroimmunology and glial biology, which is actually the section that I'm writing. So I'll talk about that a little bit later, but happy to be part of it.
Yeah, absolutely. Yeah. It's been, for those of you who don't know, which none of you probably do, Jen and I had a phone call, I think it was around Christmas time, where I essentially begged her to be part of this, to give her neuroinflammatory expertise on this. So very excited to have her on board. And then Bridget, I think for you, I'll personalize the question a little bit more, but I know that you have scoured all of the literature. So I guess from that standpoint, how have we taken both what we see in clinic, but also from literature and put that in this guideline?
Yeah, great question. So thank you all so much for being here. It's such a privilege to be able to speak with all of you. And to answer Dr. Koch's question, which I think is a great one, the section that I've been working on has primarily been clinical evaluation. So my goal has been kind of to take a step back and outline broadly what we think the overall approach should be to evaluating and managing a patient with GSD4 or APBD. And I think the overarching principle that we've kept in mind as we've been writing this is that this is such a clinically heterogeneous disorder. And we know there's so much variability in the age at onset and extent of involvement across multiple systems, which can include the liver, skeletal muscle, nervous system, heart, and other tissues as well. And in the past, I think there has been a tendency to categorize patients with GSD4 and APBD into subtypes or these sort of clinical boxes. And I think what we've learned from our exhaustive review of the literature is that there are some potential limitations of this approach. And in reality, a lot of patients exhibit features of more than one of these so-called subtypes. And there's overlap even between GSD4 and APBD, which have previously been thought to be somewhat separate clinically. And so I think as we've been writing this guidelines, we've tried to keep our recommendations very comprehensive and also very broad, with the idea that we want to make sure that we're not missing occult complications or disease manifestations that might be missed if we took a more narrow approach to evaluating and taking care of these patients.
This was unplanned, but that was a perfect segue into my next question, because my next question is going to be, how have each of you taken measures to address considerations for both GSD4 and APBD? So as we know, this guideline is for both, so we're targeting children and our adults. And I know that we've had extensive conversations about how do we merge those two, still keeping certain guidelines, I guess for lack of a better word, separate, but we're acknowledging that this is a spectrum and that there could be sectors of care that are involved for all these patients. So I'll start off with you again, Dr. Landstrom. How have we taken considerations for cardiology for both GSD4 children and adults?
Yeah, Bridget and Becca, you're hitting on kind of, I think, the major challenge of doing this in a systematic way. There is so much phenotypic overlap between the two entities, and there's heterogeneity. And so even within a classic diagnosis of APBD, there's oftentimes differences, very, very almost bi-directional differences in how the heart can actually respond to that diagnosis. And so taking a step back, I kind of threw the diagnoses out the window and said, let's go based on what the heart looks like phenotypically. I'm a simple guy. My box is about this big, right? And so it makes it very easy for me to limit my recommendations and based on how the heart looks. Broadly, regardless of the underlying diagnosis, there's many different ways that this disease can present in the heart. The two major ways are either a dilated cardiomyopathy, which again, regardless of how you got there diagnostically, is the same clinically in that the left ventricle dilates and loses systolic function, or it can be thickening of the heart, hypertrophic cardiomyopathy. Both of those entities are treated very specifically more broadly. So of course, this is the first time these types of guidelines have been put forward, but we know a lot about how to treat hypertrophic cardiomyopathy of other genetic causes. We know a lot about how to treat dilated cardiomyopathy of other genetic causes. And so those guidelines exist, and we were then able to sort of implement best practices for those guidelines based on the cardiac phenotype.
And I realized I should have said a caveat. I don't mean to scare every APBD patient thinking everybody has cardiology or cardiac involvement. It's more just like Dr. Landstrom said, regardless of how we get there, whether it's affecting our children or adults, those best practices can still be applied. Sorry, I should have led with that. But Diksha, I guess targeting the question towards you as well with GSD4 and APBD. So in your experience, I know some of the best practices are the same, but are there any differences or ways that you're incorporating your experience with both diagnosing pediatric GSD4 and APBD? Oh, we're muted again, Dr. Bali.
Got it. So pediatric GSD4, it is little easier to diagnose based on enzymology, because there are whichever phenotype in pediatric GSD4 you have, the enzyme activity deficiency or reduction is pretty clean and clear, and you can give a clear diagnosis. And also histology is a big help in diagnosing if there is a biopsy done, like, muscle biopsy or liver biopsy. The histology is a big help in diagnosis of children and babies. But as in APBD, the diagnosis becomes a little more difficult based on enzymology, because there is a variability in enzyme activity levels. It could range from anywhere from like 8 or 10% to 30%, right? So then also we have tried, but skin fibroblast, which is an easily available tissue, also gives us activity about sometimes about 10% or up to 30%. So you cannot give a diagnosis if our activity is not in a deficiency range, and we do not have enough experience and a specific range for APBD patients. So again, histology is a huge help to diagnose APBD patients, especially, and of course MRIs, and the muscle biopsy diagnosis is diagnostic. If there is a basically sural nerve presence in the piece of biopsy, it is more diagnostic than it's just piece of quad muscle, right? So it depends where the patient is coming from and the person who did the biopsy, how much they know about APBD, did they capture the right tissue, right muscle in order to have a clean, clear diagnosis. And histology and EM plays a huge role in bringing multiple pieces together: enzymology, histology, and EMs, and of course, molecular diagnostic to have an accurate diagnosis for APBD patients. Because as Jennifer said, there are overlaps with other neuromuscular diseases. So to tease this one out, you need to have 3-4 things come together to have an accurate diagnosis and put a label on a patient that this patient has this particular phenotype of GSD type 4.
Yeah, excellent. No, I couldn't have, you hit every point I was hoping you would hit. So Dr. Ortho Murphy, so I know yours is more centered towards APBD, but is there anything that, as you were thinking of for your section, for keeping in considerations for both pediatric and adult? And if there's none, that's okay too. I'm just curious.
Yeah. So, I mean, this is a really great question to keep in mind. And it's something I am constantly thinking about, because we actually, for MS, are an age span program where we are clinically closely associated with the pediatric neurology program that diagnoses MS, and also with the leukodystrophy program at Children's Hospital that diagnoses, who they know way more than I do about leukodystrophy. And so because of that, in adults, I am still going to send them to the metabolism experts that don't exist on the adult side of medicine. They're at the children's hospitals. And to even think of that for an adult is something that's important to consider and have access to. From the standpoint of thinking of what's happening in the brain, children that have an overlapping phenotype of the disease, having biopsies of the nerves as well as MRIs early on to know when do things start, which areas are affected first, how do things change over time. I don't think we quite know the answers to all those questions and how the different mutations affect that. And so to be able to think about it across the spectrum, and then within the pathology itself, for example, early developmental and young adulthood, adolescent myelination, where the white matter is affected, has much different metabolic demands than adulthood, where you've already established all of these cells and their function. And so how does that change their requirements, and maybe could answer questions about why this APPD presents in adulthood, for example? And we don't really understand any of the answers to those questions yet.
Yeah, you're making me think about how even in our own clinical practice, even just from these guideline discussions, which we hope will expand to the rest of the world once they read it, but how we've started thinking about questions we can ask our own patients, because I know a common complaint from patients is that, and from us as well, is we're all specialized in our own niche area. So understanding what are some other questions that we could all be asking to capture some of these, I know MRI would be more specialized, but even just the urology part, even in our children, of how can we start identifying if maybe these symptoms are happening earlier on, or even in adolescence or things of that sort that we're not necessarily asking at a neurology, well, I guess neurology would you would, but you know what I mean? If we're going to medical genetics, we might not be asking about that part if we don't know that that's the issue. So Bridget, I know you've been you've been very instrumental with writing and helping me merge the GSD4 and APPD space, or pediatric and adult space. So is there anything that in your personal, experience with it, if you want to expand on anything that we've taken and how we've looked at the writing of this and how we can make sure we want to still acknowledge that some things for APPD patients and our pediatric patients, there might not be the same. Some are going to be specific to different populations. So I guess that's kind of a existential question, but if there's anything you want to speak to on that.
Yeah, definitely. I mean, I think that's a great point, because whenever you're writing guidelines for such a broad and heterogeneous disorder, there is this kind of balance that you want to strike between being comprehensive and universally applicable, but also specific. Because like Dr. Koch said, it's not necessarily the case that every patient needs exactly the same evaluations. And so I think kind of the way we've dealt with this is that we've sort of laid out a set of recommendations for clinical evaluations that is very sort of multidisciplinary in nature. So that could include various physician specialists like hepatologists and GI doctors, neurologists or physiatrists, cardiologists, geneticists, and of course, other health professionals like physical therapists and dietitians. And we sort of see this as like a broad range of recommendations that may be applicable to consider for every patient with APPD and or GSD4, while also recognizing that for some patients, some of those particular recommendations may be more important than others. So for example, for a child with GSD4 who's showing progressive hepatic disease, it may be more important for them to have very regular abdominal ultrasounds and laboratory monitoring and follow up with the hepatologist. Whereas for an adult with APPD who doesn't seem to have any evidence of liver involvement, but does have neurological concerns, it may be more appropriate for them to have close follow-up with their neurologist and physical therapist. So we've sort of tried to strike that balance, but it is definitely a challenge.
Yeah, absolutely. Thank you. And so one, I was just checking the chat, one I did not mention that I feel like is important to mention. Before we even began these discussions and throughout our many discussions for writing these guidelines, a subset of us did meet with different patients as well. So throughout this conversation, so both our children, the parents of our children, and then also some of the APBD patients that were willing to share their experience in a more personal format. So that way we could understand, because we also want, we can read the literature all day long and we can talk to the specialists, but we want to make sure this is really going to be a benefit to the patient's lives and not just, what we think is important. We want to hear directly from them. So we've been able to have this conversation. So thank you, Jeff, for pointing that out. And then Natasha had a question. So is there a documented transition between a childhood type 4 GSD4 diagnosis to an adult onset polycystic body disease? I wish I had an answer for you. No. And I think I'll touch on that in the natural history. I know, Disha, you're shaking your head. But yeah, I wish we did, because I think that's been our biggest struggle with writing this guideline, is there is no obvious transition, and every patient can be so different in the rate of progression, the onset of what symptoms are even, presenting with. So I think that's what our biggest challenge, if I were to rank our challenges, I think that's been one of the biggest, but something that, to Bridget's point, that we're trying to address with how we keep it separated, but also acknowledge that there's definitely going to be cases where things could overlap. And then, okay, so Jeff, the question, can you discuss optimal scenarios under the guidelines for multidisciplinary care of APBD patients? Okay, so I'm thinking, so I don't know if one of you wants to take that, but I guess how you would approach the multidisciplinary care. So how are we creating this to be, I guess, Bridget, I think you alluded to it the most, if I could just call on you, that you talked about how it's meant to be for multidisciplinary care and not just one specialty.
Sure. So in the guidelines, we're sort of recommending that patients be at least evaluated at baseline by a range of different specialists, again, to make sure that even a patient with APBD who doesn't have any known history of cardiac disease, for example, might have a workup just to make sure that they don't have underlying issues, because we know that GSD4 and APBD are a spectrum and there are those risks. But once a patient has had kind of a baseline evaluation and there's maybe a better understanding of what their specific needs are, then I think the specialists that they follow up with regularly can be tailored to their particular needs. So perhaps a urologist, a neurologist, physiatrist, physical therapist, whatever is needed in their case. But I think one of the things that we are trying to accomplish with this guideline is to have a lot of this information consolidated into one place that maybe patients can share with their physicians, and so that we can avoid that tendency to kind of get siloed in one particular specialty and lose sight of the big picture. So we're hoping to make that a little bit easier by putting this out there to be available to specialists so they can understand kind of what the big picture is and what other issues a patient might be dealing with.
This brings me to my next question. Bridget, you're just reading my mind. In what way do you foresee using this guideline in your own practice, whether it's in your own practice or also how you envision the patients using this? So I know we kind of alluded to it, but just in your personal opinion. So I'll start off with you, Dr. Landstrom.
Well, I think Bridget sort of stole my idea, because she articulated it so beautifully. I think, for me, my biggest takeaway from a document like this and how I will use it is to actually remember that there are things besides the heart, and that the considerations that we make for one organ system need to be thought through the lens of my colleagues who know a heck of a lot more about the other organ systems. And a reminder of that is just sort of the multidisciplinary nature of all the authors on these guidelines, of all the people that are before you today, and having all of that consolidated to a single document, so that I, as maybe a subspecialist, don't lose track of all the different people and organ systems that I have to account for, is, I think, particularly valuable, and something that I hope the community finds valuable about this document.
Dr. Bali, do you envision this being used in a particular way with diagnostics and enzymology?
I think based on the guidelines documents we have developed for other GSDs, that has been a very, very helpful document, which a patient living anywhere, where there is not a specialized care available or they don't have a specialized doctor very close to home, they can take that document to their physician. It is basically a guideline document meant for any physician who is treating APBD, even if they are not very specialized, they are not very well versed, so that they basically read through the document and they can point it to the things they need to be careful about, things they cannot ignore, or things that could help a patient get better. And also from my standpoint, I think the odyssey of diagnostic, which all the patients have gone through, you all know much better than I do. There is a huge gap of in years, how long it is taken for a patient to get diagnosed, going from specialty to specialty to specialty. We hope that this document, what we create, will try to reduce that gap and would guide the early diagnosis and a physician's specialties that are needed for accurate diagnosis of a patient, no matter which type of GSD it is, but specifically APBD patient, because there is a huge time lag in the accurate diagnosis of these patients.
Yeah, absolutely. Dr. Orthan Murphy?
My general approach in clinic, I have an electronic health record, is to sort of systematically go through, if I can, disease specific, how this affects your daily life, how our interventions are helping. And these are all the areas we discussed and where to make recommendations from. And that can be, if it's for my MS patients, and my number one is my disease modifying medication. And then next is symptomatic therapy, right? And so we don't have a disease modifying medication yet here, but we will. I mean, if you attended yesterday, we will, right? So if we can get all the other pieces in place and have that sort of systematic, and if you see me as a super specialist, I can share that with your local doctor. I can point people in the right direction. You can find the APBD Research Foundation and find the information, and then sort of spread that out to all your specialists. I think that's how I would see from my perspective, and then educating others to know that there's actually a lot of this symptomatic care. We're not basing it on data necessarily because we don't have it yet, but it's symptomatic care that we do for more common disorders, and you actually know what to do.
Absolutely. Bridget, anything else to add?
No, everyone else has done such a great job, I think, of capturing what we're trying to say. The one thing I'll add is that, we've had the privilege of taking care of a few patients with GSD4 in clinic, and something I've heard from them is just frustration that it's very challenging to find providers who are familiar with GSD4 and APBD and who are comfortable caring for these patients. And we just hope that this will make it a little bit easier, and to give patients the sense that the people that are taking care of them have some understanding of what's going on.
You saying that, Bridget, makes me think of one other thing too that I know I think I alluded to yesterday with someone in a chat room, but that in the medical genetics community, these physicians were trained typically for pediatrics, and now everyone is becoming older and older, which is amazing, but there's no adult specialists for the most part that are focusing on, genetic diseases. So even having this for even experts in medical genetics who understand the pediatric form of glycogen storage type 4, I don't have to tell the APBD community that that's not necessarily the case for them. So being able to give that to them as well. And one of the things that made me think of this was what no one wants to talk about is insurance. But I don't know if a lot of you have run into this, but with the insurance companies not knowing much about a disease. I see Jen shaking her head too, but not knowing much about a disease. So having a physical document that explains not only what the disease is, but also how it needs to be managed and how it should be managed can be very helpful to for providers to give insurance companies to have certain things approved, whether it was a specific wheelchair or some sort of assistive device can be hugely helpful as well. So there was another question here. Do you know of any case of a GSD4 Anderson patient who's aged enough to show APBD neurology symptoms? So yeah, Dr. Kaplan, you're speaking my language. This is a personal interest of mine. So there has been one published case, and then this is something that I hope in the next month to 2 months will be out from our group. So I really do hope to share that with you. We've learned a ton from our natural history study. So I hope to share that with you also. This is a personal plug of mine. Thumbs up. Okay, so my next question for you all. So we've spent hours planning and writing this guideline. I don't need to tell you that. but there's been many fruitful discussions that have come out of it. And so is there anything that you want the scientific and research community, so that's primarily who's here right now, is there anything you want the scientific and research community to know, or anything you wish we specifically had more information on? So it likely won't make it into this guideline, given we don't have the data on it, but anything that you personally wish that we could look more into. So I'll start with you, Dr. Landstrom. We'll just go in the same order.
I mean, I think like with all rare diseases, I think the challenge is the number of patients that you have to draw broad conclusions from, and the heterogeneity of disease, sort of like we've talked about. And I think if I could have one big ask for you all as the clinical care and the scientific community, would be keep publishing your cases. I think as much as we can learn about the spectrum of disease, and oftentimes in my way of thinking about it, it's the denominator that matters. And so, for example, the cases that tend to make their way into literature tend to, say from a cardiac perspective, be the most extreme cases, right? A pediatric onset heart failure that requires transplantation, for example. No one talks about all the cases that do just fine from a cardiac perspective. And so I think, large registries, multi-center cohort studies that really get at that use for inclusion, say a molecular diagnosis as inclusion criteria, and then prospectively and retrospectively track, say, cardiovascular phenotypes over the course of some period of time, I think would be tremendously beneficial to learn, how many patients are truly affected. What's the penetrance from a cardiac perspective over time? What's the variability of expressivity over time? And then some sense as to how they do and how they do with specific medications. I think perhaps with these guidelines, we'll be able to lay basic sort of foundational guardrails for considerations of pharmacotherapy in the setting of cardiac disease, which should not usurp, of course, individual judgment. You've got the patient in front of you, you know more about them than we do, but hopefully some just guidance to give some general perspective on therapies to be considered. And then feedback. Did we hit the nail on the head? Did we get it right? Were there complications that we did not anticipate with those medications? Perhaps thinking outside of the cardiology box, right? Does a beta blocker, say, for example, have impact elsewhere? And so all of that will be tremendously helpful as we continue to refine sort of best practices.
Yes, no, absolutely. You made me think of one thing that my mind has lost. So I was reading the chat while also, I was going to say, you made me think of exactly you mentioned case studies, but also natural history studies. So I know I wear a double hat with the natural history study that I will not talk about right now. I'll talk about that next, but to play devil's advocate to myself, I think there's a huge role. I'm not a cardiologist. So when you bring up cardiac transplant or anything else, anyone who's writing from our natural history study could never do justice to what a full documented case report on a specific outcome, or again, not biasing towards poor outcomes, what a good outcome was as well. There's role, I think, for both. So even when I talk with patients about why natural history studies are important, but also why published case reports are important as well, we want to know that, because that's I know from the guideline perspective, we run into this, is we don't know the specific dosages that patients were given if there was a surgery, all these very small details that are hugely important when we're talking about the care of these patients at large, that, we just don't have because it was very vaguely reported in the literature, because that, maybe wasn't what they were trying to focus on. So anything else to add, Dr. Ortman Murphy or Dr. Bali, on that? So what you wish we knew more about, at least for your sections?
What I would like to say is that which Dr. Landstrom hit, already has said, that sharing the data and what outcomes were there based on what genotypes or what the patient was, what was the outcome. This data, of course, from natural history is coming. In the not too many years back, there were only 4 or a few variants known in the Ashkenazi Jewish population. And they said, if you have to have APPD, you have to have one of those variants. And that is how they were diagnosed. They were just looking for those 4 variants. But now collecting the data from sequencing is more common. People are sequencing the whole gene. And you have come across that APPD can be caused by many variants. Not just for those 4 variants, which have been published extensively in the Ashkenazi Jewish population. So I think in coming years, collecting data, collating the databases, and looking at the long-term outcomes of patients and the therapies and the physical therapies we all are going to learn much more about GSD4 and APBD and what is the presentation really like at what age. And we all will learn it together, I think. That is the point we are at now.
Absolutely. Dr. Orthen-Murphy, did you have anything else to add?
I think you have all covered really excellent asks, which are significant. I think I'll just throw in some very practical things going forward with the clinical guidelines, and just from experience of taking care of both MS patients, undiagnosed patients, and then APBD patients, is something like we can make as many recommendations as we want to say to go to physical therapy and go to physiatry and that sort of thing. But what are we actually asking for when we send them there? And what does the physical therapist understand about what the goal is? For many of these disorders that are progressive, the goal is to not get better, like you broke a bone and you go back to normal. It's actually for maintenance, and you have to keep doing it, and you have to keep doing that. And that requires education on a lot of people. And I've actually learned that there are physical therapists that are specifically trained in MS. So I now say things like, even though you don't have MS, ask for a physical therapist who's trained in MS, because that will change their expectations for how to take care of you. And so, going forward, like, what are the challenges that people are facing in their care, symptomatic care, so that we know how to help people do that.
What a great segue, because if you attend our session later today, we will be asking that exact question of, what is it that from a patient perspective, you feel like it's a burden of care that we could better address here. But just for the chat, real quick, I just saw some questions. So they were echoing what you were saying, Dr. Landstrom. And then, did you consider guidelines for pre-symptomatic younger patients? And that's a wonderful question, Lydia. So in that, we luckily from our natural history study have learned of patients who were diagnosed, typically females, from prenatal counseling and prenatal testing. And they were unexpectedly, diagnosed for the APBD side to be either, having a genotype that we would expect to go on to develop APBD. So for those, it was mostly the awareness and, or bringing awareness to this disease, which hopefully if they had genetic testing, they should have been talking with a genetic counselor. But if not, talking about that and what the expectations can be, and if there's any certain steps that they should take as well. So we are trying to highlight that field, because we know, especially with the prevalence and the access to genetic testing now, that we're probably going to be seeing more and more of those cases. Is there anything that you all would add to that? I saw some nods, but okay. Yeah, Disha?
No, I was just going to make the same point you did, that now because of the prevalence of genetic testing, maybe we will find out, as we have found with other GSDs, that this is underdiagnosed disease. Maybe not everybody who has the disease is being picked up. So the more we look, more we will find. That is, I think, we are going to be in that arena in coming years.
And I think the beauty of this too is these guidelines can always be updated in 10 years from now. This is not something that's a permanent, it's definitely a start, but it's always open for improvement. And there was a question from Cheryl: how will we share these guidelines with relevant professional associations? For example, the American Academy of Neurologists. It's so important to educate. 100%. So it will be open access, this document. But I know even Dr. Landstrom, I know you brought up before of how to get this word out for our pediatric population about inherited cardiomyopathies or things of that sort as well. And I know Jennifer and, I know the Research Foundation as a whole has been trying to get the word out to the MS community about this needs to be on their list of differential diagnosis or ruling out this diagnosis as well. But is there anything you all would add to, in your experience, how you've shared these guidelines and gotten it out to the community that's not in the rare disease space and isn't aware of this? Dr. Bala, you want to start? Oh yeah, Dr.
Oh,
yes,
sorry.
Go ahead. No.
I was just going to say that Dr. Kolodny encouraged me to present at MS-related conferences. So we did to one of the main MS conferences this past year, sort of presenting a few patients and what features were similar and what distinguished it from MS. And so that these could be the red flags to think, well, I shouldn't give this person a disease-modifying medication for MS because it won't help them and their side effects, and maybe they need to go get genetic testing. So that's the goal. But I mean, that's a great idea. I think publishing the guidelines, where they get published, changes your exposure, I think, but also then presenting at the conferences that they have is the major way to do it.
Yeah, Dr. Landstrom, anything to add from a pediatric perspective?
Yeah, I'll wear my cardiovascular genetics hat for a second and say, in addition to just good old-fashioned family and provider awareness, I think some of the role to understand the underdiagnosed population probably lies at the diagnostic intersection. And so I think in my mind, there's two ways to go about this. The first would be to engage private sector genetic testing companies. I'm thinking of places like GeneDx and Invitae to add these kinds of genes to their cardiomyopathy gene panel to pick up children with maybe principally cardiac disease phenotype early in life, and perhaps they're being seen by somebody like me who's not a trained medical geneticist and can't, I'm no good outside of my box. And so perhaps accounting for that by having broad gene testing might have a role. And the other way is through ClinGen, which will establish at least a relationship that can be vetted over time and puts it into a space where medical geneticists tend to look when gene mutations come up in genes. And so there's resources such as that, which can be leveraged so that when these mutations end up in the hands of people who may not be familiar with the gene, they have a resource. And there's actually an effort now to convene pediatric cardiomyopathy ClinGen curation working groups that overlap with congenital heart disease. And I think something like this would be carried forward into those groups as potentially a new association.